Well, good morning, ladies and gentlemen. It's a real pleasure to kick off the proceedings this morning, talking on the contemporary management of aortic pathologies. As the oldest and most senior member of the team, I've been involved with management of aortic pathologies for over 25 years. I started endovascular repair in Oxford around 20 years ago, and I'm delighted to say since that time we've got over 10 people who can now undertake endovascular repair, and we've also evolved a complex team looking at more difficult or more complex anatomies in a smaller, close-knit team, and we can now deal with pathologies pretty much from the aortic valve down to the bifurcation, either through open surgery and or hybrid and or endovascular repairs. So I'm going to talk about imaging for aortic aneurysms and the anatomy. So what is the role of imaging? Well, primarily it's diagnosis and then staging, risk stratification, getting functional anatomical information that helps planning and guiding therapies, as well as, of course, follow-up. Plain films have a limited role. Echo, MR can be incredibly useful for problem solving and also assessing patients, but CT remains pretty much the workhorse. And again, nuclear imaging and angiography is really much more fourth line. So predominantly, we're going to talk about aneurysm disease, and of course, most of these will be due to atherosclerosis, but acute aortic syndromes can result in development of aneurysms as well as inflammatory diseases. I'm not going to spend a lot of time talking about basic anatomy, other than to say it's important to, of course, know where all the structures are and to understand the common variants, but also some congenital pathologies that really either result in disease or may impact on treatments. The humble chest X-ray has been around a long time. If you're lucky enough to have calcification and calcification in the aneurysms, it can help you dissect and assess disease to a limited degree. But pretty much we're moving on to using cross-sectional imaging. MRI has moved and progressed from being able to give standard 2D imaging to giving us fantastic images of aneurysm disease, dissections, stenoses, but also being able to give us functional information as to what's going on and sometimes help plan patients better. However, the majority of times it's very much used as a tertiary imaging modality. 4D imaging, of course, it gives us fantastic images, but also allows us to assess flow and to look for pressure gradients that will, of course, help assess underlying disease pathologies, but generally is limited use when we're looking at aneurysms and aneurysm management. PET-CT, of course, has an incredibly useful role, particularly when we're looking at inflammatory diseases. This is an example of Takayasu's. You can see enhancement in the aortic wall, and then we get better anatomical information with the CT showing us areas of stenosis and dilatation, as well as inflammatory changes and aneurysm change in this patient. Of course, nuclear scans, PET-CT, again, can be really useful in infected aneurysms or picking up infections following surgical repair. And we can also use it to help decision making. This is an example of a patient with a type A dissection treated not that long ago, and the dissection extended all the way down to the bifurcation, but involved multiple vessels, including the renal arteries, and a decision had to be made as to whether we should treat the renal vessels with those dynamic and static obstruction, and we could see that there was still good perfusion in these vessels, and so we could hold off doing anything about it immediately. But the workhorse, as I've alluded to, is pretty much CT. It's evolved from when I was a lad to single slice scans through to spiral and multi-slice scanning, so we can get isovolumetric examinations, so we can produce fantastic reconstructions and give us better anatomical information, particularly when we're looking at aneurysms around the aorta and the aorta and the arch. And it can demonstrate all sorts of pathologies exquisitely. This is intramural hematoma, penetrating ulcers, inflammatory aneurysms. This is aneurysms associated with Behçet's and Ehlers-Danlos syndrome. Infective aneurysms are really problematic. There's this classical drape sign and erosion of the vertebral body, and of course gas, which is a real giveaway into the aneurysm sac. This is the first infected aneurysm ever treated in Oxford 20 years ago with a thoracic stent graft, and this patient had a very good outcome right up to 4 years. As CT has evolved, and I set up cardiac CT in Oxford around 10, 11 years ago, we could not only get really good reconstructions of the coronary arteries, and of course assess coronary arteries non-invasively. It was a real opportunity to look at aortic and aortic pathologies, and my hope was that we would be able to do routine gated scans for all our aortas. Sadly, haven't still achieved that, although we've got lots of cardiologists and radiologists trained. We don't have enough radiographers to provide a 27 gated study, and this is really important because it can be really problematic for dissections, for example, where you get artifact with movement in the ACL and the aorta suggesting a dissection. Here you can see a non-gated study showing an artifact suggesting dissection, but when you gate it, it's not there. Here again, this looks like a dissection, but again, with the gated study, it's not there. ACL and aorta arch, possible dissections. When you gate it, you can see that this is clearly not the case. Now, the patient has an established dissection, and the suggestion being that there may be a type A dissection more proximally, but when you gate it, it's clearly not the case and changes the management of this patient. So we can get really good quality imaging now. We can look for the tears and assess these better, as well as, of course, get better quality imaging and reconstruction. And as we start to extend the range of treatments using complex endovascular and hybrid repairs, both below and above the diaphragm, and now we're starting to do arch branch stent grafts in Oxford, it's really important to get the best quality so we can plan these patients. And planning is key to getting the best outcome for our patients and getting good medium and long-term results. And of course, in the near future, we may be starting to do on-table constructions of complex devices. We need to really get good images right from the start. There are key features for any aneurysm that we need to assess: neck length, whether we do open or endovascular repair, and the quality of that neck, whether it's calcified or there's thrombus, or whether it's a conical or reverse conical neck. Ideally, we want necks, or if there's severe angulations, which can compromise not only delivery of the stent graft or the repair, but also the longevity treatments. When we're looking above the diaphragm, we need to know if there's a steep Gothic arch, which can make delivery of devices difficult, as well as landing them accurately quite complex. And then, of course, we use imaging for follow-up, and there are some unique complications of EVAR, endoleaks in particular. And it's really important to understand what type of endoleak we're dealing with: type 1, 2, 3, or 4 or 5. Type 1 needs immediate treatment, as does type 3, whereas type 2 you could potentially hold. Here's a case of a fenestrated stent graft where we had initially what appeared to be a good result, but then anatomically there's a problem with failure of the proximal stent fully dilated, and we had to go back in and dilate this and flare it to make sure that the superior mesenteric artery did occlude. Another patient with a thoracoabdominal type 4 aneurysm, and we used a T branch in this case. And again, we've got a really nice result, and the CT shows that we've got good flow into the vessels, into the branches, and there's no endoleak, which are key we need to ensure. Here's a case that I think George did recently with a type A dissection with an aberrant subclavian, and this was treated with a frozen elephant trunk, and you can see a really good result, and here's the stented portion of the device, and this patient has a really good outcome. And this is our most recent arch branch case with a thoracic aneurysm, and this patient had a very good outcome. So just to say, I'm delighted to be a member of this exceptional team, which is delivering really high quality care with the latest technologies available to us in Oxford. Thanks very much for your attention.
Good morning, everyone. I would like, first of all, to thank the organizers of this meeting for inviting me here today. Also, let me thank you all for attending in this busy time. Today, I'm going to speak about basic principles of anesthetics for aortic surgery, including deep hypothermic circ arrest, brain protection, spinal cord protection, and troubleshooting. Anesthesia. Plan your anesthetics with ODP, with the team. Pre-operative team briefing. Plan to the perfusionist. Hemofiltration drugs, ISO. Check patients fasting. Anesthetics in theater. Any malperfusion. GCS, any changes. Any ECG changes at the last minute. Any spinal cord ischemia. Cord legs movement. Standard American Society of Anesthesiologists monitoring is very much applicable. Selection of the site for intra-arterial cannulation is important. We use bilateral radial arteries for blood pressure monitoring, which helps also to check for bilateral selective antegrade cerebral perfusion. Also, it helps for the checking the patency of the axillary artery if it's been used as an access. If thoracic aorta is involved, then femoral artery would help too. Brain monitoring is typically employed. We use EEG and we use cerebral oximeter. If we use cerebral oximeter, it's very much advisable to start it before anesthetics. Also, we use pulmonary artery catheter. Pre-op TOE is very important. If you are dealing with emergency type A dissection, you have first to confirm diagnosis. You have to check for pericardial collection. You have to check for regional wall motion abnormalities, LV function, RV function, valve function, mostly AR. This is transgastric short axis view to tell us about any wall motion abnormalities. And these are mid-esophageal 4-chamber view. You have seen like the RV and the LV is not working properly, and the RA again is very dilated, and the LA is very dilated. Again, here in the 4-chamber view, check for any like unexpected surprises. They are highly likely to see with type A dissection. Check for hollow diastolic flow reversal. More importantly, confirm diagnosis and don't be misled with artifacts. Aortic dissection is highly lethal condition with mortalities increased by 1 to 2% per hour within the first 24 hours when the ascending aorta is affected and surgery remains the only option. A week last Sunday, 76-year-old man was diagnosed with type A dissection at 1:30. He was in theater at 2:50. This could have been one of the fastest to operate on in this difficult time. The patient is doing very well at the moment. Organ protections are very important when deep hypothermic circ arrest is needed for aortic arch and high thoracic aorta surgery. Brain protection achieved by deep hypothermia, retrograde, antegrade cerebral perfusion by drugs, all in order to reduce the cerebral oxygen consumption. This slide shows the relation between hypothermia and cerebral metabolic oxygen consumption. As we can see on deep hypothermia at temperature of about 18 to 20, we have about 20% oxygen consumption from normal. At profound hypothermia at temperature about 10 to 12, we have only 10% from oxygen consumption. This slide shows the effect of hypothermia on EEG going from normal activity around mild to moderate hypothermia down to deep to profound hypothermia. We can see there's electrocortical silence. Packing the head with ice during deep hypothermic circ arrest has been shown to improve mortality and neurological recovery. Ice packs is another neuroprotective agent. This is my way of doing ice around the head. Most of the papers showed evidence that thiopental provided cerebral protection when used alongside hypothermia. It also lowers cerebral oxygen consumption and produces electrocortical inactivity on EEG. Be careful of timing. Normally, I give it within 5 to 10 minutes pre-circ arrest and watch blood pressure. Methylprednisolone offers safe and inexpensive strategy for cerebral protection, but timing is important, at least more than 2 hours pre-circ arrest. Selective antegrade cerebral perfusion with oxygenated blood at rate of 5 to 7 ml per kilo per minute and a pressure of 60 to 70 millimeter mercury measured in the ipsilateral radial artery. Arterial perfusion could be unilateral and or bilateral. Retrograde cerebral perfusion with cold oxygenated blood to the SVC cannula at rate of 150 to 250 ml a minute. Troubleshooting for regional cerebral oxygen desaturation should be available. Review your checklist, cannula position, CO2 level, HP, mean arterial pressure, pump flow. Physiological effects of deep hypothermia, including bleeding, diaphysis. Make sure that you ordered your products on time for off bypass. Again, another one is cardiovascular effect. Make sure that your inotropes is available and ready to start. Hyperglycemia due to stress response, steroid administration, catecholamine, please correct accordingly and make sure that you are not making your patient it's hypoglycemic by the end of the case. High thoracic aortic surgery require more protection, require spinal cord protection by drops, cooling, lumbar drain. Lumbar drain should be by one atraumatic attempt. This is algorithm for the treatment of spinal cord ischemia after thoracic aortic repair. Includes troubleshooting, communication between surgeon, anesthetist, and intensive care, and the neurologist too. This is weaning off bypass checklist. Should check your temperature, rate, ABG, ventilation, electrolyte, level the table, inotropes. Aortic surgery is very complex and requires a high level of communication between all teams. Troubleshooting should be available for any problem might happen. Finally, this is DeBakey classification for aortic dissection. This is mid-esophageal view for the ascending aorta. We can see here the dilated ascending aorta, and then here we can see a proper flap on the ascending aorta to show the aortic dissection. And in this view, you can see the amount of AR, which is just like a protop by the ascending aorta dissection and the dilated aorta. This is Michael DeBakey, a pioneer aortic surgeon. At age 23, developed the roller pump. At age of 97, DeBakey himself suffered aortic dissection. He was the oldest patient ever to survive aortic dissection repair. Thank you very much indeed. Stay safe, stay well.
Hi, this is Mr. Shakil Farid. Thanks for the invitation to give this talk. I'm going to talk about the principles of surgical management of aortic aneurysm. In my talk, I'm going to cover the indications for surgical intervention, the principles of surgery, and the latest developments that took place in our Oxford Aortic Team within the last few years. The disease process in the proximal aorta prior to the origin of the left subclavian artery varies slightly from the disease pattern in the distal part of the aorta, which includes the thoracic and abdominal aorta. And the aneurysms of these two different parts of the aorta has different rates of growth, with the proximal part having a growth rate of around 0.1 centimeter per year, as opposed to the distal part, which has a growth rate of 0.3 centimeter per year. The risks of complication varies in the two parts of the aorta. In the ascending aorta, the hinge point is 6 centimeter, at which level the risk of complication increases exponentially. In the descending aorta, it's 7 centimeter, where the risk of complications increases. As you can see, in an aneurysm of more than 6 centimeter size, the combined yearly risk of rupture, dissection, and death is around 15%. The thresholds for intervention on the proximal part of the aorta depends on the situation. In patients with Marfan syndrome with risk factors such as family history of aortic dissection or increased rate of growth or pregnancy, uncontrolled hypertension, the indication for surgery is 4.5 centimeter aortic dimension. Same goes for patients who is undergoing concomitant aortic valve surgery. In patients with Marfan syndrome without risk factors or patients with bicuspid aortic valve with risk factors, the threshold for intervention is 5 centimeters. In patients with asymptomatic disease, when the aortic dimension reaches 5.5 centimeter, surgical intervention is required. This includes patients who have bicuspid aortic valve without any risk factor. In patients with Loeys-Dietz syndrome or Ehlers-Danlos type 4, the indications for surgery can be lowered up to 4.2 centimeter. Indexed height and body surface area is also important, as it has been shown to be associated with increased risk of complications. Prior to surgery or in patients with known aneurysm who haven't reached the threshold for surgery yet, it's really important to control emotional and physical stress as it raises the blood pressure and increases the risks of complications. Smoking cessation, aggressive statin therapy is also important. In order to reduce the heart rate and blood pressure, beta blockers and angiotensin receptor blockers are used. According to evidences, angiotensin receptor blockers are useful in patients with connective tissue disorders. I'm going to talk about the basic steps of surgery. The commonest incision is midline sternotomy incision. After the incision, it's important to establish cardiopulmonary bypass by putting a cannula in the arteries and having a cannula in the right atrium. The commonest cannulation technique is central cannulation, where a cannula is put into the ascending aorta. This is enough for replacing an ascending aorta or doing a replacement. However, in patients who need to undergo aortic arch replacement, various other cannulation techniques are used, which involves, in order of frequency, the right subclavian or axillary artery cannulation, the innominate artery cannulation, less commonly the femoral artery cannulation. The problem with the femoral arterial cannulation is that if you have an aorta like this, the debris can go to the brain and cause stroke. In situations where there are serioaneurysms or in the reduced settings, carotid artery cannulation is quite helpful. Surgery depends on the segment of the aorta that is involved. There can be isolated dilatation of the root or ascending aorta, or combined dilatation of the root and ascending aorta, or dilatation of the aortic arch. Thoracoabdominal aneurysms are usually dealt by the vascular surgical team. In cases of dilatation of the aortic root, a modified Penton procedure can be done, where the valve is replaced either with a tissue valve or a mechanical valve, and a supravalvular Dacron graft is put in, where the coronary arteries are reimplanted. In patients with aortic regurgitation and a structurally normal valve, valve-sparing root replacement can be done. It has been shown that in good experienced centers, this can achieve a freedom from valve reintervention of up to 85% in 15 years in younger patient group. Homograph can be used, especially when there's aortic root abscess, and the stentless valve can also be used. In cases of isolated dilatation of the ascending aorta, a simple ascending aortic replacement is performed. Homograft can also be used in these situations, and a modified Bentel is done if the root is dilated in addition to the ascending aorta. Sometimes the ascending aortic dilatation extends into the proximal part of the aortic arch, in which case a hemiarch replacement is performed. Surgery for aortic arch aneurysm is much more complex. In order to perform this procedure, a bloodless field is required, which is achieved by deep hypothermic circulatory arrest. When the core body temperature is reduced, the metabolic requirements of the brain reduces as well, which enables to perform the procedure with circulatory arrest safely. In addition, when selectively blood is provided to the brain, potentially the temperature can be increased slightly to perform the procedure with moderate hypothermia. During the deep hypothermic circulatory arrest, 10 ml per kilo blood is provided to the brain, either by the right axillary cannula that has been used for arterial inflow, or by putting cannula directly into the head neck vessels, whilst monitoring the cerebral saturations and maintaining a right radial pressure of 50 to 70 millimeter of mercury with a flow of 10 ml per kilo per minute. Previously, for replacement of the aortic arch, which is aneurysmal, a conventional elephant trunk procedure was performed where a branch graft was used to replace the arch and proximal part of the head neck vessels, and at the distal end of the graft there was another Dacron graft which used to go inside the descending aorta. However, for the last 1 year, we have been using the frozen elephant trunk at Oxford, where there is a stent at the distal part of the branched arch graft. Having this stent at the distal part has few advantages. There are few advantages to the frozen elephant trunk technique. It essentially converts a two-stage procedure into a single stage. As you can see on the diagram, in the conventional elephant trunk, the patient first undergoes the stage 1, where the arch is replaced with a branch graft, then the floppy graft is put inside the descending aorta. The patient then undergoes the stage 2 procedure, where another graft is anastomosed to that graft which has been put inside the descending aorta, or patient undergoes TVAR. Problem with this is up to 50% patients can be lost between the stage 1 and stage 2. However, with the frozen elephant trunk, the whole thing can be done in a single procedure in most of the patients. According to different studies, only 1/3 of the patients come back for a second stage procedure. In conclusion, aortic surgery can be simply awful or awfully simple. It's important to follow the basic principles of surgery, which is first, do no harm. It's also important to keep the procedure simple and have a protocol so that everyone understands what the operation is going to be and how the operation is going to be performed. It's important to prevent malperfusion, especially malperfusion of the brain and the heart. And finally, teamwork is really important in order to achieve excellent results. Thank you for your attention.
I'm going to talk to you about the contemporary management of pathologies afflicting the thoracoabdominal aorta. When we talk about thoracoabdominal aorta, we normally focus on the area distal to the left subclavian, extended down to the bifurcation of the aorta in the abdomen. The aorta itself is obviously a continuous conduit that starts at the aortic root all the way down. Some of the distinctions we make for the different parts of the aorta sometimes pertain to how we manage pathology within these areas and which specialty takes this on. The picture on the right does give us a more accurate way of delineating different aspects of the aorta, with a zone 0 area just in the ascending aorta, extending all the way down to zone 10 down by the bifurcation of the aorta. By doing this, we're able to ensure that when we discuss research articles that we are talking about the same thing. So, what pathology do we treat? Well, primarily, most people know about aortic aneurysms as being one of the commoner conditions that we encounter within the segment of the aorta. But acute aortic syndromes also form a significant part of the workload, and these include aortic dissections, as well as intramurally hematoma and penetrating aortic ulcers. Trauma also forms quite a significant workload in this area, particularly from rapid deceleration injury, and I'm primarily talking about blunt traumatic aortic injuries. And we mustn't forget that connective tissues disorders also play a significant part. And on this slide essentially demonstrates some of the conditions that are encountered in different parts of the aorta. As you can see, the ascending aorta, which is really the domain of the cardiac surgeon, although we're encroaching more and more into this area using more novel endovascular techniques. The rest of the aorta itself, you would see that aneurysmal disease affects all parts of the aorta, and as further down you go into the abdominal aorta, we tend to see more occlusive disease as well as aneurysmal disease in this segment. So when we look at the incidence of aortic aneurysm, by far the commonest part for this to occur is in the infrarenal aorta. And the suprarenal aorta then takes a significant part of the of the more complex aortic workload that vascular surgeons see these days. As we move into the thoracic aorta segments, then 60% of these will occur in the ascending aorta and the root, which keeps the cardiac surgeons busy, and the others will involve the descending thoracic aorta, and only about 10% involve both the descending thoracic aorta and the abdominal aorta segment. We do have a classification that we utilize for thoracoabdominal aneurysm. This has been done for quite some time now. This is the Crawford classification. As you can see, the extent 2 is probably the most complex condition that we treat, and really remains a significant challenge to the vascular surgeon. Open surgery still forms a significant part of managing some of these procedures, and I'll discuss some of the techniques later. When we look at aortic dissection, which essentially results from a tear within the aortic intima, and then a split forms within the medial layer of the aorta and can extend all the way down from the arch of the aorta right down to the bifurcation of the aorta. We know from some of the work that P.J. Howard has done that the incidence of this is around the 6 per 100,000 mark within the population. It forms a significant workload for both cardiac and vascular surgeons, and remains a particularly challenging group of patients to know when and who to intervene on. When we look at classifications of aortic dissections, classically they're divided into type A and type B, and type A dissections essentially involve the ascending aorta, whilst type B are dissections that extend distal to the left subclavian. This area in the arch of the aorta where we have a non-A type, non-B type group is becoming more and more frequent, hence the need for collaborative working between cardiac and vascular surgeons to treat these patients. Aortic trauma, I would only touch on this very briefly. Rapid deceleration injuries can cause significant trauma primarily to the descending thoracic aorta, and these patients may come in with varying disruptions to the aorta, whereby grade 4 is the complete disruption of the aorta, and grade 1 is barely a hematoma that you may see in the wall of the vessel. Treatments are primarily reserved for patients with grade 2 and above. If we then look at how we treat these patients, open surgical repair has been the mainstay for many years. Now, the mortality associated with open repair of thoracoabdominal aneurysms can be quite significant. There is certainly a center volume effect, and in the best centers, you may get mortalities below 10%. But if you look at historical data, then mortality from dealing with extensive thoracoabdominal aneurysms can be as high as 20 to 25%. With the advent of endovascular treatments, we've certainly reduced the mortality that we see from this condition. But open surgery still remains very important for patients with connective tissue disease, and but these really should be carried out with a combination of probably cardiac and vascular surgeons in specialist centres. If we look at the type of devices that we now have available to us, well, technology has certainly has run ahead at pace here. We've got devices that we have fenestrated windows cut into these devices, and they're custom made for individual patients. We also have branch endografts, which can be used almost as off-the-shelf grafts these days for ruptures. And in real emergent settings, we have the options for putting pellular grafts in, where we run the main device alongside a small stent that goes into targeted visceral vessels. Our techniques for actually carrying out this procedure have also improved, whereby in the past we would have cut down onto access vessels. We now use percutaneous approach in order to deliver rather large sheath sizes into our access vessels, and we're able to really deal with some complex cases, even including type 2 thoracoabdominal aneurysms in an expedient fashion. What are the outcomes from this? Well, systematic reviews have been attempted for these conditions. I must admit, some of the data that we get from these are not coming from randomized controlled trials, and so a lot of these will have confounding factors in it. But if you look at this Canadian paper, the mortality from endovascular treatment is approximately 7%, whereby that from open surgical treatment for all comers with thoracoabdominal aneurysms is about 9%. Now, you've got to remember that in this group, if you looked at the detail of this, that these patients, actually, the patients in the endovascular group had significantly higher comorbidities. And so endovascular treatments have certainly taken off as being a mainstay for treating a lot of conditions. One needs to be aware that placing a stent graft across these across visceral and head and neck vessels is never a good thing. And so in order for us to ensure that we maintain perfusion to these areas, we have adjuncts that we tend to use, which involve open surgical techniques such as carotid subclavian bypasses, which will maintain spinal cord perfusion. We do arch to branching procedures, which involves taking a graft from the ascending aorta up to the head and neck vessels to allow us a good landing zone for placing the stent graft. Most recently, here in Oxford, we have adopted the arch branch technique, whereby we have a aortic stent graft that is custom made for our patients, and we are able to deliver this in the zone 0 ascending aorta, as well as mating stents into the carotid vessels, having done a carotid subclavian bypass. These are challenging cases, and we do require cardiology support for these in order to ensure we have rapid pacing of the heart to deliver this stents accurately. One area that is really pushing ahead at STEAM is the research area in these groups. We really need to have to identify the patients that will most benefit from these conditions. And as such, my colleague Regent Ian Ashok-Ander have been heavily involved in looking at both biomarker and radiological predictions for aneurysm growth, which I think will help us further understand who we should be using these techniques on. So in summary, I just wanted to give you a flavour of some of these very challenging cases that we do. The technology itself has advanced significantly over the past 20 years, and it allows us to treat a greater number of patients. Collaborative work is clearly the key, and having complex aortic teams that deal with these patients will ultimately bear fruit with better outcome. And all of this obviously needs to be underpinned with good research. Thank you.
We're going to move now in discussing a little bit further about aortic dissections, in particular type A aortic dissections, and some controversies that surround the treatment of aortic dissections and aortic aneurysms. Aortic dissection is a sudden catastrophic event in which we have a separation of the aortic wall intima, which allows blood to escape from the true lumen of the aorta and rapidly separate the inner from the outer layer of the median. The blood passes through the tear and either causes an acute rupture or the formation of a new channel called false lumen between the two layers. The false lumen can extend from the tear to proximal or distal parts of the aorta, causing malperfusion to other organs. The aortic dissections are divided broadly in type A's and type B's. Type A's, which are the most frequent one, have a tear or a false lumen that involves the part of the aorta before the left subclavian artery, i.e. the aortic root, the semi-aorta, and the aortic arch. This is a surgical emergency. The type B's, on the other hand, are less frequent. The tear and the false lumen are after the left subclavian artery and usually managed conservatively with blood pressure control and on occasions with a surgical intervention. There are more males affected than females and usually appear in the 6th and 7th decade of life. And 90% of the time, they present with a sudden severe pain. Aortic dissections, especially type A aortic dissections, are life-threatening conditions. Affects about 4,000 people in a year in the United Kingdom, but only 1,200 of them survive to be admitted to the hospital. In essence, aortic dissections kill 1,100 more patients in a year than all road traffic accidents in the UK, based on 2018 data. What are the keys to saving lives? Awareness among doctors and health professionals, but also rapid access to CT scans to diagnose the condition. To me, every patient that dissects is a patient that we, the medical community, have failed to protect. And to that extent, I would like to discuss with you a few controversies to shed a bit more light to that statement. The first question I would like to discuss is when to perform a prophylactic surgery and if size is everything. We know that the risk of rupturing is higher if the dimension of the aorta is increased above 5.5 centimeters. We also know that the risk of complications is increased significantly at an aortic size of 6 centimeters for a semi-aortic aneurysm, with a yearly rate of rupture, dissection, and death being 8 times higher than smaller sizes aneurysms at the range of 3.5 to 3.9 centimeters. We also know that 40% of the dissections occur when the size of the aorta is less than 5 centimeters, and probably over 20% when the size of the aorta is less than 4.5 centimeters. We also know that we do not wear the same size shoes or the same size gloves. To that extent, we do not have the same size native aortas. So we should not really wait for a 1.5 meter tall little lady to grow her aorta to a size of 5.5 centimeters, because that's enormous for her size. And equally, we should not be rushing to operate on a basketball player of 2 meter, 2 meter 10 tall, because probably a 5 or 5.5 centimeter aorta is enormous size for him. We also know that certain pathologies like bicuspid aortic valve are associated with elastic module and collagen issues related to the aortic wall and what we call as bicuspid aortopathy. We also know that rheology and aortic wall stress matters, especially if there is an aortic regurgitation or aortic stenosis. And the aortic wall stress is increased along with the dimensions of the aorta in a proportional manner. Now, if we add to that pregnancy, cocaine abuse, bodybuilding, and weightlifting, then we can understand that aortic wall stress and rheology are two very important factors that we should be taking into consideration. Over the past decade, especially, we have come to understand better the influence that genes have and the fact that there are a number of genes that are associated with the increasing diameters of the aorta, and also that the vast majority of families with an inherited predisposition for thoracic aortic disease have no associated syndromic features, with, of course, one very obvious example of exception being the Marfan syndrome. RNA signature and metabolic activity are two very important factors. And it is not unusual to find patients suffering from aortopathies when they dissect. Positive family history of dissections is also a very important factor that we should be bringing into the discussion, as these families, they dissect more, they dissect at a younger age, they dissect faster from the diagnosis to the time of the dissection, and they have a much higher risk in comparison to the rest of the population. Finally, high blood pressure. I think blood pressure is the means by which an aortic wall ruptures or dissects at the vast majority of cases. And it's surprisingly that even today, a large number of patients, they come to my outpatient clinic with a very big aortas of the size of 6 or 7 centimeters and a systolic blood pressure that remains untreated and as high as 180 or even over 200 millimeters of mercury. So in a nutshell, size is not everything. And this is why we have the Oxford Complex Aortic MDT, where all these factors can be brought together, analyzed, and decide on when to perform a prophylactic surgery with patients and stop them from dissecting. And as we operate on more dissections with ever decreasing mortality year after year, we do indeed operate on more males than females. And a proportion of these patients are well over the age of 80. In England, we estimate that over 3.5 million are over the age of 80. And we expect that at least 200 of them will suffer an aortic dissection within a year. In Oxford, we do operate primarily on males rather than females, and about 5 to 10% of them are over the age of 80. With regards to the 80-year-olds, the post-repair survival beyond the 1 year remains reasonable and as high as 50% at 5 years. However, the functional outcome and the quality of life for these over 80 years old patients with a dissection that have been operated remains a question mark. One contemporary question is who should be treating these patients? Dedicated aortic centers or every cardiac center in the country? And of course, in 110 miles and 40, we have 5 centers with 7 counties and equal number of ambulances, services, commissions, everything. But one thing for sure, we should be having a tariff that reflects the complexity of the operation, and we should make sure that we do not fragment our resources, especially in a time of crisis like the COVID pandemic. Does region matter? Yes, it does. When we look to the NICO registry on how many dissections were performed per million people, we can see that year on year, Oxford is in the middle of the hottest spot of dissections in England. With that, as a last slide, I would like to conclude this series of lectures. I would like to thank you very much for your attention, and we would like to open the floor to questions.